is by Dr. Audrin Lenin on the updates of hypertensive disorders during pregnancy. Dr. Audrin is an associate professor in the Obstetric Medicine Unit, Department of Internal Medicine, CMC Vellore. He is a member of Institutional Quality Steering Committee and COVID-19 Treatment Protocol Development Team. He has multiple presentations at national and international conferences and has been the author of numerous publications in peer-reviewed journals. His academic interests include medical education, including curriculum development and faculty training, obstetric medicine, focusing on hypertension and pregnancy-related complications.
So I'll be talking about what is new and what are the recent updates in hypertension in pregnancy. And I'll briefly talk about what are the updates in the definition, how can you predict hypertension in pregnancy, what are the updates in prevention, updates in diagnosis and management, and finally the long-term implications of hypertension in pregnancy. So I'll mainly use these two as my guideline for the talk, the SOMAN's guidelines, which came out last year, and the ISHEP guideline, which came out in 2021. So when you talk at updates in the definition of hypertension in pregnancy, so these used to be the old definitions. And to understand the updates in the diagnosis, you should understand what were the changes in the diagnosis of hypertension in non-pregnant. So after the Second World War, what happened was people found out that people who had high blood pressures, when they died and when they did autopsy, they had this thickened blood vessels, and what we now call atherosclerosis. And they've thought that this high blood pressure was important for this patient to push the blood across these thickened blood vessels. And that's why they called it essential hypertension. And later on, we realized that that's not actually how things work. And they found out that it is not essential hypertension, and the terminology is changed to systemic arterial hypertension now. And so something similar happened with pregnancy also. People were worried to bring down the blood pressure in these patients because they're worried the placental perfusion will reduce and you will have fetal growth restriction. And so the blood pressures were kept as high as possible without causing any problems to the mother. But later on, we realized that that doesn't exactly happen. So, and the definitions have now come down to BPs more than 140/90. And this was due to a landmark trial called the CHAP trial, which came out in 2022, where they randomized patients to a strict BP of less than 140/90 versus a BP cutoff of 160/105. And they found out that when they looked at the primary composite outcome of preeclampsia, medically indicated preterm birth, placental abruption, and neonatal death, they found that a low BP cutoff was much better than a high BP cutoff. And what everyone was worried about, that if you bring down the BP, you will have small for gestational age babies. They found that there was no difference in that. And so they, because of this trial, where it showed that lower BP cutoff is much better than a higher BP cutoff. So now the recommendations have changed to a BP cutoff of 140/90. When we look at the definition of preeclampsia, this we all know, the proteinuria, liver involvement, HELP syndrome, platelets being low, DIC, all of this are the old concepts. What is something new which is coming in is the placental biomarkers, where you look at abnormal uterine artery, umbilical artery Doppler, oligohydramnios, and abnormal SFLT PLGF ratio. I'll come to that in a little bit more detail. One more change which has come in is the term eclampsia has gone up. So eclampsia now comes as part of preeclampsia as a neurological involvement. So previously eclampsia used to be a different terminology from preeclampsia. Now it is a part of the neurological involvement of preeclampsia. Coming to the placental biomarkers, so this comes to the concept of angiogenic imbalance. So there are two molecules which are of importance here. One is the placental growth factor, which is PLGF, and second one is a soluble FMS like tyrosine kinase receptor, which is SFLT1. So the PLGF is a pro-angiogenic molecule, and SFLT1 is an anti-angiogenic. So you need a balance of both of these for the placenta to have blood vessels which go into the uterus. So to put this, explain this, I've just put this picture where normally you have the placental growth factors, which cause the placenta to enter into the myometrium, cause the spiral arteries to be formed. And this is the yellow things are the placental growth factors. These go and attach to the FLT1 receptors which are present on the endothelium. So when it goes and attaches, it causes a angiogenic, pro-angiogenic effect. What happens to inhibit this is there are soluble receptors which are floating in the blood. And when this attach themselves to the PLGF molecule, this molecule can no longer go and attach to the endothelium. So when you have high PLGF, it prevents preeclampsia. When this SFLT goes and attaches to the PLGF, your blood vessel formation is affected, angiogenesis is affected, and you develop preeclampsia. So this is the whole concept of these two molecules, which are the placental biomarkers, which have come into the picture now. And what is the role of this biomarkers is you can predict preeclampsia much earlier than waiting for the blood pressure to go up. It has now become part of the definition of preeclampsia itself. And in conditions where you have underlying proteinuria, patients with chronic kidney disease, patients with chronic glomerulonephritis who already have proteinuria and you're worried, do they have preeclampsia when in pregnancy? This is useful to differentiate these two components. So this is just explaining how it is. If you have a SFLT-PLGF ratio less than 38, that means you are less likely to have preeclampsia. If it is more than 85, you're 100%, almost 100% sure that the patient has preeclampsia. In between that, you need to take your clinical judgment. So the angiogenic markers are available, can be used after 20 weeks of gestation. And the other things which have come in are the fetal Dopplers. Uric acid is slowly being phased out of the diagnosis of hypertension. So when we look at screening for women at risk of preeclampsia, the old, this thing was based on history, looking at the risk factor, whether they have the major risk factor or minor risk factors, high risk or a moderate risk, based on this to say whether they are at a risk of developing preeclampsia or not. So this was based on the 2019 NICE guidelines, which was which is worked up on the 2010 guidelines. But the problem with this is the sensitivity of this screening test is only 22%. So if you're using something as a screening test and if you have a sensitivity of only 22%, that is not a great screening test. So what we are going now is something called triple screening, where it's clinical, where you look at risk factor history, which we talked about with mean arterial pressure, along with radiological, which is uterine artery Doppler, and finally biochemical using the placental growth factor. So this gives a sensitivity of around 70%. So over the West, everyone's moving more towards the triple screening rather than just the risk factor screening. And there's an easy calculator online available where you just put in the details which you have available, and it will give you a risk based on that. This is the Fetal Medicine Foundation calculator, where you just put in all the details which you have. Even if you don't have some of the details, you can still put in this calculator and it will tell you what is the risk of them developing preeclampsia in the future. Why this is important is because there are new things which have come in where you can prevent preeclampsia. And the easiest and the most cheapest drug is aspirin. So aspirin, starting aspirin at less than 16 weeks of gestation in people who have high risk of developing preeclampsia has shown to decrease the incidence of preeclampsia. So when you look at starting aspirin before 16 weeks, after 16 weeks, the risk of developing preeclampsia, early onset preeclampsia, preterm birth, small for gestation age babies, all of this is much better in aspirin. Then people looked at what is the dose, and when they compared less than 100 versus more than 100, more than 100 was better compared to less than 100. So the dose which we used is an aspirin dose of 150. And when they looked at the timing of aspirin, they found that bedtime aspirin was much better than afternoon aspirin. So we recommend for prevention of preeclampsia, aspirin 150 mg at bedtime for people with high risk. The other thing which has come up is calcium supplementation, another low-cost drug easily available, where if they have low dietary calcium intake of less than 1 gram, it is shown to prevent preeclampsia in this women. But this doesn't seem to work if they have a daily calcium intake of more than 1 gram. So this works only if the dietary calcium intake is less than 1 gram for the patients. Looking at updates in diagnosis, so when we talked about the proteinuria for diagnosing preeclampsia, the previous investigation of choice used to be dipstick, but they found that now it's changed to urine protein by urine creat ratio or urine albumin by creat ratio. And this is because the sensitivity of the dipstick is only 22%. So again, not a great screening test. So the guidelines are moving more towards the urine protein creat ratio. And sorry, the other thing is what I talked about, the SFLT-PLGF ratio. This is a very good rule out test. It's not so great for ruling in. So if your SFLT PLGF ratio is less than 38, you can rule out that this patient will get preeclampsia in the next 4 years. But if it is more than 38, it doesn't give much of an information. So, sorry. So this is clinical assessment plus SFLT PLGF less than 38, you can rule out. If it is more than 38, you need to wait and watch this patient. Few other updates. One is management of high blood pressure, acute severe hypertension of more than 160 by 110. So here question is, do I give IV labetalol or do I give oral nifedipine? And when they compared, they found that oral nifedipine is better than IV labetalol. So you needed less doses. It brought down the BP faster. So seems little contrary to our logic, but oral drug here, oral nifedipine is better than IV labetalol. Only if the patient is not able to take orally, has a seizure, is the only place where you would choose an IV labetalol over an oral nifedipine. And the other thing is, if someone who has a high risk for developing preeclampsia at less than 30 weeks, you can give magnesium for neuroprotection, which has shown decreased, shows risk reduction for death, cerebral palsy, gross motor dysfunction, and also for intraventricular hemorrhage in the newborn. So these are all things for neuroprotection of the baby. And finally, when we come to the long-term implications of hypertension in pregnancy, so large cohort studies have found that preeclampsia is a major cardiovascular risk factor. So having preeclampsia is equivalent to smoking. So it's a 2 times higher risk of developing cardiovascular. So it is equivalent to smoking. And this risk is much higher in people who developed early onset preeclampsia compared to someone who developed late onset preeclampsia. And if a prevalence of any coronary atherosclerosis after history of adverse pregnancy outcomes is around 32.1%. And they have also found that this is a dose-dependent effect. So if you had 2 pregnancies where you have preeclampsia, your risk goes much higher than compared to 1 pregnancy with preeclampsia. And the other things are preeclampsia with chronic hypertension is higher risk of developing heart failure with preserved ejection fraction. And what this helps us is during the pregnancy, you can predict the future cardiovascular risk. So if you have dysfunctional placenta, if you have spontaneous rupture of membranes, all these can predict future cardiovascular risk. So the pregnancy is a time where you can identify the future cardiovascular risk of the woman. And if you have preeclampsia and you take more than 7 days to treat that, the risk for cardiovascular disease goes much higher. And now there are more studies looking at uteroplacental thrombosis during the preeclampsia time to see if they have uteroplacental thrombosis. This can be used as a positive stress test for cardiovascular stress test to see if they develop heart disease in the cardiovascular disease in the future. The other issue with preeclampsia is the higher incidence of depression, anxiety. They have higher risk of developing mood disorders. And so now the depression screen has become part of the preeclampsia management, where after delivery, you follow them up and you use the depression screen to screen for postpartum depression in this woman. Few other things which have come in because of this SFLT PLGF, which I talked about. They've looked at targeted therapies where A, you can increase the PLGF, B, you can block the SFLT. So increasing the PLGF, where they give in animal models where they have tried giving VEGF, which has shown to improve outcomes there, but it's still not tried out in humans. The problem with blocking SFLT is they have issues with lung and heart development in the animal models. So when you block angiogenesis, you block angiogenesis all over the place. So you need to give it only in the placenta at that time. And placenta is a very complex organ. So if you give anything in, no large molecule crosses across it. So getting it across the trophoblast is a difficult challenge here. So these are the problems with drug discovery, targeting PLGF and SFLT in these conditions. Thank you.
Thank you, Dr. Audrin. Before we move on to our next talk, I would like to invite Dr. Lakshmi to come up to the front to